Okay, let's get started. So thank you everyone for joining for today's session. I'm going to start the session by first thanking our sponsors, Connection Healthcare Enterprise, and Cheryl Casal, who's with us today. She's the healthcare director for sales at Connection Enterprise Solutions. She's going to say a few words about Connection, and then we'll officially start the session. So Cheryl.
Good afternoon, and thank you, Viraj. Um, I have the opportunity as a clinician to lead a wonderful team at Connection Enterprise, which is a global solutions provider. In my years as a clinician for the past 25 years, I have seen many, many things in healthcare, and it brings passion and conviction. And looking at diversity and inclusion and how we approach this crucial juncture in how we are effective and enhance the abilities of all of us through technology to truly encompass patient care to the next level. I have the ability to lead a wonderful team, and local to you all is Rob Foreman, who is a graduate of Drexel and lives right in the Philadelphia area. Today, we'll be talking about diversity and inclusion and have a esteemed panel with us. Mr. Gilbert Davis from CHOP, who is the VP of and Clinical Diversity Officer. We have Judy Sabino from Lehigh Valley Health Network, who is the Chief Diversity, Equity, and Inclusion Liaison. We have Lizette Martinez from Jefferson Health and Thomas Jefferson University, Executive Vice President and Chief Diversity Officer. And of course, our moderator of the panel, Gail Sidson Smith from CHOP, who is the Associate CIO and AVP for Business Applications. Gail, I'm going to turn it over to you to lead our esteemed panel today.
Great. Thanks, Cheryl. And thank you everyone for joining us this afternoon, our esteemed panel. So I'll jump right into it. As each of you work in healthcare organizations, can you explain to our audience how you're approaching diversity in your own environment? And Judy, let's start with you, please.
Good afternoon, everybody. It's a pleasure to be with you today. So I'm from Lehigh Valley Health Network, and we began our sort of diversity and cultural awareness initiative more than 14 years ago. And at that time, our goal was to get it in the pipes. And that was kind of the phrase that we used. So it would just inform everything that we were doing. So the idea is that this is everybody's job. As an army of one, I can't sort of hold all of that responsibility on my back. So it was really evident to our colleagues that this is everybody's job. We have a very broad definition of diversity: race, ethnicity, language preference, sexual orientation, gender identity, educational background, socioeconomic status, all of those things, ability and differing abilities is included in our definition. And that commitment goes from leadership all the way down to our individual contributors. So actually, one of the last things we did before the pandemic struck was we celebrated the 10th anniversary of our Cultural Awareness Leadership Council. And then throughout this pandemic, this summer, our CEO, Dr. Brian Nestor, actually instituted an additional kind of leadership council looking at specifically racism and equity. And so we're really delighted with the fantastic work that they're doing. And so I have the honor of supporting this work, and it's work that focuses on colleagues in sort of some traditional diversity and inclusion space, whether we're talking about recruitment, we're talking about performance management, we're talking about education and development, whether we're talking about succession planning, all of those kinds of things. And we use a colleague engagement survey that we do annually to really measure our success there. But then we also think about patients and families, and we have some culture-specific programming, whether we talk about veteran health or Centro de Salud, which focuses on bilingual or Latino community. But we also provide cultural consults for patients and families, have a great story if anybody wants to hear about some of that work. And then also really focusing on analytics and using our patient race, ethnicity, and language preference data to inform how we go about doing our work. And that has been so essential, especially during COVID. So that's kind of how we approach it at LVHN.
Great, thank you, Judy. Lizette, why don't we jump over to you?
Okay, thank you so much. Yes, thank you. And I want to thank you all for the opportunity to speak to this group. It's the first time that I've been approached for speaking to you all. So I'm grateful and with gratitude, thank you so much for the invitation. So yes, as the EVP of Diversity, Inclusion, and Community Engagement for Jefferson, we're really working hard to build operational planning for the organization. So we don't just look at diversity and inclusion and equity in just one area. We look at covering diversity and inclusion in all corners of the organization. And so in creating an operational plan for diversity and inclusion, we've actually worked to begin listening to our employees to understand how we execute a plan in addressing the needs and the challenges that they discover and working with them face to face. We've developed a blueprint for action that covers a strategic direction, and we actually have strategic dimensions that we work specifically in order to be able to address some of the concerns that employees, leadership, faculty, and students have within the institution. And so some of these strategic areas include leadership and governance and how we actually assign accountability to the organization. We look at marketing and communication and how we address both internal and external marketing, and how the organization looks overall, both the university and the health system. We want to make sure that whoever walks into the doors can see themselves on the walls, right? So we make sure that we have planning in place for that. We have also a people category in which we look at, representation, internal mobility, what does that look like for our organization, and how do we sustain diversity and inclusion? We have another pillar called experience that includes, what do students experience? What do our patients experience within our institution? And our employees experience as well. And then our external stakeholders. Another key area that's incredibly important for us is economic inclusion, and how do we include our vendors in the process of providing access to make sure that they have the opportunity to bid and get awarded contracts. It's more important now today to make that happen, and it's our responsibility with the complex organization that we have and the footprint within Philadelphia and South Jersey to make sure we keep those connections open as well. So everything that we do lies within the mission, vision, and values of our organization. Our values are strict with putting people first, being bold to think different and doing the right thing. And so we want to make sure that our operational blueprint for diversity, equity, and inclusion covers all of that.
Great, thank you, Lizette. And Gilbert, if you could share your initial thoughts, please.
Sure. Good afternoon, everyone. Thanks for having me. It's a pleasure to participate, and I see a lot of familiar names in the participant list, so you're all probably used to hearing me talk about this, but I'll go ahead, give it a shot. And our approach is similar to what Judy and Lizette said. We've been at this for a number of years, so our foundation is already set. We've tried to pivot a little bit based on the current civil unrest and what's happening in society. And so that has been eventful, but still we keep to our structure and our strategic plan. One of the things we're doing initially is as a leader, I've gone on a listening tour, and I think Lisette mentioned that. I've gone on a listening tour to hear the thoughts of the workforce, the staff, the patients, and the families, because we did not want to build a strategic plan for diversity, equity, and inclusion in a vacuum. We wanted to hear the voices of those that were impacted. And so that was our initial step this fiscal year, to just embed the customer's voice into what we were doing in terms of framing out diversity and inclusion. And it's an enterprise-wide initiative. Some of the progress we've made to date includes we've assigned associate chairs for diversity, equity, and inclusion that are embedded in departments of surgery, departments of pediatric, those types of areas, because we want to be in the proximity so when we make actionable steps, they can be done at that level and really ingrained in how we do our work. As Judy said, it's an office of one, and in my case, an office of four. So this is the work of everyone at CHOP. We've expanded our diversity council to include more faculty and staff from across the enterprise, not just leadership. We've also developed a workforce diversity infographic and made that accessible for all of the staff to see. So there's transparency there. So we're able to share our gender, our racial makeup, the diversity of our clinical staff. We've also established a health equity center, or we're in the early stages of developing a Center for Health Equity to look at disparities across race as it relates to healthcare delivery. And that was really brought to light with the discrepancies in the number of cases for COVID-19 as it relates to Indigenous people, Native Americans, Black, and Latinx and people of color. So that's a big initiative where we're looking to centralize that work. We also are continuing our community health program, our Healthier Together program, where we've committed, a really large bucket of money, millions of dollars, to make sure we're catching those social determinants of health that also equate to diversity, equity, and inclusion. We've funded a number of STEM programs. There's a lot of bullets that I could go down, and I know we don't have a lot of time, but our commitment is sustainability. And what we've done is started to really look at how we can have a sustained program. We don't want it to be a priority. We don't want it to be an initiative. We want to embed it and ingrain it in the culture of CHOP. And every leader has been embracing that approach. In fact, we've also implemented a diversity metric for the CEO and direct reports of the CEO to ensure that racial diversity is among CHOP's leadership. And that's something that's bold, because you can have your positive and negative reaction to that, but that's something that bold, and that shows me that we're just not we're walking the walk. We're just not talking. And then lastly, externally, we're involved in a lot of things. So for example, I'm on the Philadelphia Anchors for Growth and Equity, which is Page Group. And basically that's a partnership between the city of Philadelphia, the Economy League, and more than a dozen plus Philadelphia area institutions that works to increase local purchasing by institutional buyers, to grow Philadelphia businesses, to grow underrepresented businesses, to grow military-owned business, women-owned business, all abilities-owned business, just to strengthen the local economy, create jobs, and build wealth. And so for me to have that external view and bring it back to CHOP so we can work on our diversity initiatives and our supplier diversity program is all a part of the grand picture. So I'll stop there and we can continue, but that's just where we are in terms of our program.
Great, thank you, Gilbert. Lizette, this next question, we'll start with you. So at Jefferson, you're continuously having dialogue with the employees around having brave conversations. Could you explain this concept and how it's helped during these difficult times?
Absolutely, thank you. So I want to say, we began having these brave conversations, and I'll walk you through what brave conversations is. It's an acronym. It stands for bold, relevant, authentic, valuable, and educational conversations. It's really an opportunity for anyone in the organization who participates to share their opinions and concerns on topics that might be a little uncomfortable, but really necessary to discuss and address. And it's an immersion experience designed to compel thoughtful and productive dialogue. But as you can imagine, now I began working at Jefferson very recently. I started in May, and just as I arrived here in May, we all experienced the murder of Mr. George Floyd. And that sparked heavy unrest and the need to connect with our employees at a different level and make sure that our health system and our university had an outlet to really lift the heavy and painful feelings that everyone was experiencing. So we created this platform as a safe place for voices to be heard. And what came from this was the opportunity for participants on a virtual platform using Zoom to learn from each other about our own experiences with discrimination as employees, as customers, as parents. Incredible, powerful conversations that really heightened the awareness of what some people never understood and helped increase really the compassion level to better understand the need to acknowledge the need to better educate ourselves and intentionally make efforts of cultivating an environment of inclusion. So more so for me and my team, we not only heard these incredible stories, but we also heard the heartfelt concerns as to the challenges that Jefferson has in moving forward. And these conversations really led to learning from our employees face to face what we need to do to bridge the gaps of disparity and address systemic racism. So in the months of June, July, and August, this entire summer, we continue to have daily brave conversations. And I personally conducted all of them in the month of June and spoke to over 1,200 employees. We have since then also trained 25 facilitators to conduct these talks. And now it has become a signature program for Jefferson Health and Jefferson University. The most important detail from having these brave conversations is that we were able to capture the advice and the needs from our enterprise, that we were able to develop that operational plan that I spoke to you about, that really has become our blueprint for action for our DEI efforts. So we took that work our employees provided as an assessment and converted their concerns about what we needed into actionable items to execute and move with intention. We released our plan as we had promised last month with the strategy statement, with our strategic dimensions that I talked about, and a focus area for each of the strategic dimensions. So we have even presented for the very first time in 196 years to increase the percentage of non-white in leadership roles by division, which means that all supervisors and above, we are looking to increase our non-white population by 30% by the year 2025. This has been approved at a board level and it's tied to our incentives. This is an incredible goal that we are moving forward with. We are looking to also have other goals where we look at internal mobility, where we look at our rates and tracking of discrimination cases. We are looking also at our supplier diversity spend. And also when we think about employee engagement, employee experience, student experience, patient experience, and also our performance review numbers as well.
Thank you, Lizette. Gilbert, you and your team have helped a lot of employees with unconscious bias. Could you speak more around that and give listeners advice on how to avoid the unconscious bias?
Sure. So we have done a lot of work in this area. I'm not really keen on the term avoidance. I like to say I prefer disrupting unconscious bias. That to me feels like more in tune to the current environment. There's no magical future in which we don't have unconscious bias. We all have it. We all have a brain, so we're all going to have some type of unconscious bias. And if you feel like you don't have any unconscious bias, you're lying to yourself, quite frankly, because we all have it. We're hardwired to have unconscious bias the way we've grown up and have, lived throughout our lives and built certain customs and cultures. So we all have it, and we're hardwired to have it. But I look at disrupting bias, and that's how we teach it, disrupting bias. And we look at it in 3 steps. The first step is to take a look at your own bias. I mean, really go deep. Look at your circle. Look at those around you. Look at those you associate with. Who do I spend time with? Who do I not have exposure to? We recommend taking, and we do implement this, we take the implicit association test, just to see where we land in that testing to figure out where our gaps are and where we need to improve. And then we ask for feedback for those who are not like us. It's a lot easier to see bias in others than in ourselves. So that's part of our approach for unconscious bias training. We've offered this virtually throughout our enterprise. We started with our leaders because we needed our leaders to understand their biases and understand the root cause of unconscious bias before we can have them cascade that message to the direct reports and the entire workforce. So we started with our leaders. We're training all of our leaders in this space. And then in the new calendar year, what we'll do is offer it to all workforce and staff via an e-module or in-person training. That second step is to identify the times and places where you're likely to use or use these shortcuts, whether you're driving and you have road rage and you realize you're making a confirmation bias. Recognizing those times is how you change course and how you really address the unconscious biases. And that's not easy. There's 150 types of biases. So identifying the ones you lean on the most will help you target your patient's threshold. And that's really, and I do it every day where I catch myself. I'm like, that was, when I did the unconscious bias training, I recognize that I'm associating this with this, and I can't do that. And I kind of give myself a smack on the wrist and say, okay, I got to improve in that space. And it really doesn't matter your level of experience. You can be in diversity, equity, inclusion space for years and years. You'll still have these things going on. And then lastly, we recommend is just slow down, bring your decision-making from the unconscious to the conscious. Ask yourself, is this how you want to show up? Does the behaviors match my self-image? What excuses or rationalizations am I making for my behavior? And then impact matters more than intention. And I'm going to repeat that. Impact matters more than intention. Am I impacting people in the way I want to? And that's the gist of it. And so we're making sure as a standard, because we recognize that everyone's not in the same space and not everyone will be on board. But as a baseline standard, we are offering this unconscious bias so we have the same baseline as we move to more in-depth and more granular training based on the topics that we need.
Thank you. I'd like to invite Lizette or Judy to share their thoughts around unconscious bias.
Gail, can I say one more thing before that?
Of course.
So one of the things I should have mentioned earlier when I was talking about our program is important, and I know Judy and Lisette have already mentioned this, but it's important to have the entire enterprise involved. And what's key for us is our HR business partners. They're heavily involved in this work as facilitators, but also our employee resource group participants and our physician affinity groups. They have a really key role in all of this because they're passionate about the work. So for us at CHOP, this fiscal year, about 15% of our employees were involved in these groups, and that's a 13% increase over the last quarter. And so everyone's having the opportunity to get involved, and that's really key in cascading the message consistently. Thank you.
Mm-hmm. I think that everything that Gilbert said was on point. You definitely have to move in that direction. A couple of things that we're doing, with our education and what's challenging is this year is that we can't do in-person, face-to-face training, which is incredibly impactful when you can do that and have really strong, powerful conversations. But we were able to identify some e-learns that provided the tools. I think people really want to understand, well, how do you undo it? How do you uncover a bias? Because unconscious bias, you don't know you have them. And as Gilbert said, you need other people to tell you that you have them. So you have to have these conversations. So we, looked at and vetted several opportunities for e-learning to bring those tools to the organization. And we've actually made them mandatory for all employees, all students, well, not our students, but our faculty, our employees, our staff, and made it available to all of our students to take on Canvas. So the unconscious bias training is incredibly important. But along with that, we also want to make sure that we have some interventions to help when people do make mistakes. What are the conversation interventions that you can do as leaders or as colleagues, in an organization, whenever you do, witness an inappropriate statement or an action that needs to be addressed? And so we've implemented a program on speaking up called Ouch, That Stereotype Hurts, and the tools to talk to people and give them that information. But also, You as a leader can set the expectation for your team that if somebody makes a mistake, that it's okay to ask each other for help. I don't know what I don't know. Or if I say something wrong, tell me, and provide that safe space for your own departments. You need to be able to do that and talk to each other, because if we don't know we have a bias, how better will we know if we give permission for people to give that gift of feedback to let us know, so that we can begin rebuilding that and forgive each other. And then we've also provided and implemented tools on communication recovery. So if I say something, Lisette made a boo-boo, she said something wrong, and somebody called me out on it and said, Lisette, ouch, that hurt. What is it that I say? How do I then recover? And we're teaching people how to do that. This is incredibly sensitive. It's a topic that is hard to overcome. But the simple fact is, if somebody comes to you and says what you said was inappropriate, your first response should be a heartfelt, I'm sorry. And thanking the individual for telling you that, and then gaining the perspective on what it was and why it was inappropriate, and understand and acknowledge the intent versus impact, and begin to move forward to build forgiveness within the team. Listen, we work more with each other than we do with our own families. We're spending a lot of time at work. Why work with individuals you don't want to be around with? Have these conversations and build trust. And when you make a mistake, acknowledge it. And so we have implemented the communication intervention to let teams know to make a safe space, so that when you do make these mistakes, that you know how to respond to them. And then how do you recover from them yourself if it happens to you?
Lizette, I think that's fantastic. And that's going to lead into a little bit of what I can also share about what are sometimes called microaggressions. But I want to follow up on some of what Gilbert talked about, because you're right, unconscious bias by its very nature is unconscious. So the first thing you have to do is to open up that awareness to what are those automatic associations that are occurring in my brain. And that's where things like the implicit association test really come from. And then what are those tactics, or what are those strategies you can use to go from that automatic association to consider what other options are occurring to me. So it's really identifying, as you mentioned, when are those moments that I make these automatic associations, and how can I pause? How can I take that step back? How can I consider other things besides that just one go-to or reflex kind of action that I have? And in addition to what both Lizette and Gilbert talked about, the other advice that I give to our clinical teams primarily, but it can be used for whoever, is whenever you're making a critical decision, or whenever there just seems to be a time that things are not working well, that should be your signal to say, how is my bias affecting how I'm looking at this situation? And even when you have clinical consults or team meetings, when you're talking about patients and families, having as one of the typical questions you ask is, how could our biases, how could our automatic associations be affecting how we're looking at this patient or how we're looking at this family? And so the more that we can systematize this work, I think it becomes just a part of what we do on an everyday, on an everyday basis. And it isn't like, oh, here I have to go to a diversity training, or I have to, learn something that I'm really not interested in, but it really does affect the work that we're doing.
Yeah. Thank you. So Judith, you mentioned microaggressions. So
Yeah.
could you talk with us around strategies to help mitigate microaggressions at work?
Sure. Yeah. So, as Gilbert mentioned, because of our biases, because of just how our brain works, we become susceptible to things that are called microaggressions. And actually, as I've been learning, I think the work that we all do requires continual learning. So we're always learning about, how understanding these concepts, but also how to express them and share them with others. That term microaggression has become somewhat, controversial. It turns people off a little bit. Excuse me. So now they're starting to be called sort of subtle acts of exclusion. And that's really what they are. And that's kind of what Lizette was talking about. So when we make a comment, or we actually do something that in perhaps a subtle, but also sometimes not so subtle ways, we exclude someone. So we might say to somebody, oh, you're so articulate. Well, you might mean that in a very professional kind of way, but you also could say it, and the person who hears it hears, maybe that person is thinking that I'm from a group that shouldn't be intelligent or who shouldn't speak well. And the idea of these subtle acts is that when they occur over and over and over again, they really have negative impacts on the person that receives it. And it just really breaks my heart when I work with our trainees, our medical students, our residents, our fellows, who might receive these kind of comments from patients, from other clinicians in the hospital, and it just kind of wears away at their well-being. It really, it can actually lead to burnout and have poor health outcomes. And so really understanding, the first thing is, what are they? So what are subtle acts of exclusion? Keeping our eyes open for when they happen, because they do happen. And then figuring out, what am I going to do in the moment? And so, Lizette, I was like jotting down notes. Expect an email from me when this is over, because I'd love to learn more about some of the trainings that you're providing. But that's the really key moment. What am I going to do when it happens? And it really requires a bit of having a sense of the dynamic that's happening in the interaction and deciding whether I should take action in the moment, or do I take action in sort of a private way? So this idea of, do I call out or do I call in? I know for lots of people, calling out has become really popular. However, our ultimate goal is to change behavior, and sometimes calling out can have the opposite reaction, the opposite outcome. In the moment, however, it is really important, and Gilbert, I'm going to use that term that you did. We have to interrupt what's going on, interrupt the interaction. We have to be definitely supportive of the person that is receiving that subtle acts of exclusion, and sort of maybe redirecting the conversation in the moment, even if we decide that we want to follow up with the person who is initiating the interaction at the time. So maybe we want to say to them in the moment, what did you say? Or, I'm not exactly sure that you understand the impact of what you said, because it really goes back to that difference between intention and impact. Someone may not intend to be exclusionary, but the impact of their statement or the impact of their action is definitely exclusionary. So really sort of deciding, how am I going to interact in the moment, and creating a space where you really want to affect behavior change. So it's not necessarily really embarrassing the person or calling them out, but creating a conversation to say, you may not understand what the impact of that statement means and the impact that it might have on somebody else. Though, like you said, Lizette, those are hard conversations to have. And
Very
so the other key thing about addressing microaggressions or subtle acts of exclusion is practicing. So kind of having a few little phrases in the back of your head that you can kind of pull out of your pocket and kind of use depending on what the situation is, but then also following up with the person who initiated it afterward, and just really having sort of that understanding and perhaps educational kind of conversation of what the impact of what they said, and how they could do better.
Yeah.
And then Lizette, one last thing. So Lizette, I love also what you said, because we are also going to do it. So it's amazing to me that, I think about this stuff all of the time, and then something comes out of my mouth and oh my gosh, why did I say that? So I really like what you said about being aware that this happens to everybody, and not reacting negatively, not reacting with anger, but also kind of just having that self-awareness that, let me hear what the impact was that I said. How can I understand better? And then how can I apologize to the person that I offended?
Yeah, recovery.
Yep.
Recovery. Yep.
Exactly. That's what I was going to mention. And also we have a slogan here at CHOP, progress over perfection. And that doesn't just apply to our business, that applies to our diversity approach as well. So we aim for authenticity and not perfection. We aim for our leaders to be vulnerable in these times, because if you're not uncomfortable, you're not learning. And as Lisette said, this is an uncomfortable conversation. It's not easy for anyone. So we lean into the discomfort. If you're not feeling uncomfortable, you're missing an opportunity. And that's how we're looking at this. When we think of microaggressions, we use the acronym STAR, Stop, Think, Act, and Review, because reacting in the moment may lead to ineffective interactions, as Judy mentioned. So it's okay to breathe. It's okay to strategize and then follow up. You don't have to address it in the moment. Now, there are times where you just have to say, listen, ouch, as Lisette said, that really hurt my feelings, and here's why. And it may have been unintentional. It really may have been unconscious, or something we traditionally use. For example, I was in a meeting where someone was really offended by someone saying the grandfather clause. Well, that we can apply that to the grandfather clause. And they really didn't understand why that was hurtful to someone, but that someone knows the origin of grandfather clause was within slavery. And if you were a slave a certain amount of times, you were grandfathered in. And so they said, well, if I use legacy, will that work? That's perfect. And so it was just something small. We would think would be small like that, but it took an ally to help educate someone outside of the meeting. And then everyone was on the same page. So a lot of times it's not intentional, it's just not knowing. And so reacting in the moment is I would recommend that less, but I would recommend it in certain situations. And then there's the direct actions that you take, addressing the microaggressor, because it needs addressing at that time, so the entire forum or room could be educated. And so there's different approaches to that, but these brave conversations have to happen. And again, we just need to recognize that they're not going to be comfortable, they're going to be uncomfortable, but some valuable information and learning comes out of all of it.
Mm-hmm. So I want to address that there is a wonderful program that I want to share with all of you called Ouch, That Stereotype Hurts. It comes from Sunshower Productions, and it has specific tools. Now, once you get to know me better, I'm all about making sure that people have the tools up front. Judy mentioned something that you can pull out of your pocket. Well, there's like a card that you can have that has the steps for you that you can actually have. And, one of the things, Gilbert mentioned about being offended. Listen, everyone's going to make an offense. An offense is an action. But to be offended, that's a decision. And we have to make sure that when we're working with our colleagues, that we soften our hearts a little bit and give people a little bit of time to recover from mistakes that they make. Now, some are pejorative, and those need to be addressed. I'm not saying those that are pejorative shouldn't be addressed. But when people make a misstep, we have to work with folks. And the steps to doing that is, the first thing is we got to assume good intent in people. And then explain the impact of what that's the start of the conversation, right? And sometimes if you can't do that, then ask a question. Help me understand what you meant by that. So that they can understand that what they said needs to be explained a little further, right? Another one is, Gilbert mentioned it, interrupt and redirect the conversation. And that can be done immediately. Conversation's going left, you gotta make sure, hey, whoa, we're not going there right now. They need to understand what they're saying is wrong. Brought into universal behavior. Sometimes people will categorize things. Oh, that's a girl thing. I think that applies to everybody, right? Or you can make it individual. Sometimes people will classify a group of folks to all, right? All are doing this. Nah, who are you speaking of? Because obviously you're frustrated about something. And if you can't approach it with those 5 tools, what you can say is ouch, because ouch means something hurt. And words and actions like that are painful, and they live with people for a very long time, sometimes forever. And so when you say ouch to someone after something that they've said, you indicate to them that the words that they had were hurtful and painful. So if you can't do any of those other tools, just say ouch. I know it sounds kind of uncomfortable, but you know what? I tell you, your silence gives permission for the behavior to continue.
Mhm.
And when
And
you do
silence,
that, you perpetuate racism in the organization.
Mhm.
So you have to speak up, even if your voice shakes. I'm sorry to tell you.
yep.
I get nervous about it. It's uncomfortable. It's not easy. And Judy said it, you have to practice, practice, practice. You can take these tools and in your staff meetings, you can ask yourself 3 questions. 1, address. 2, how are you going to do it? Are you going to do it now or later? Gilbert was talking about when you respond, right? Are you going to get an ally to help you address it? And 3, if you look at the OUCH program and the tools, which one of these tools would you use to address it? Plan how you would do it in practice. That makes it a little bit more comfortable. And as diversity leaders, we wish we had the magic pill to take this uncomfortableness away, but unfortunately we can't. It's your intention to make change in the institutions that you work in.
You know, Lisette, you made a good point that I'm glad you made that. You need to create a safe space for the target or the person that the microaggression is geared towards. You need to create a safe space by being an ally. And so sometimes it's just not in the personality or the character of the person to speak up or to express themselves in that moment. So an ally could take that person aside and say, yes, I know that was inappropriate. How can I support you? So that way they're the voice of the person and they may have a better approach to addressing the issue. So that's so very important to have an ally assigned, you know, in that space as well.
Yeah.
This has been a great conversation so far, and I think we could, all, spend the afternoon together, but I just want to be careful of the time that we have. And I want to switch gears a little bit. Since we're all in healthcare, I think that we'd like to talk about diversity in the electronic health record, both recording and collecting data from patients. How can we address this to deliver better care outcomes? And Gilbert, I'd like to start with you.
Sure. So I come from the IT space, so I could spend a lot of time here. So I won't. I'm interested in hearing in Judy's stance. But as I mentioned earlier, part of our one of our platform items is to create a health equity center, a center for health equity, and that's to look at racial disparities with the delivery of healthcare across the continuum. And whether it's in the research space with clinical trials, whether it's in the actual acute care space, whether it's in the satellite surgery center space, whatever it is, we want to look at racial disparities and how care is being given. So a lot of that is going to be driven from what's collected in the EHR, the medical record. Now, that's the one aspect of it that we really need to be cognizant of. But the other aspect is, does it lend itself to cultural competent care? We may, and I don't want to name a specific EHR, but we may have an EHR that doesn't have a bilingual option, that doesn't have, an option for a different race or culture. And so how can we have this patient population feeling as if they belong in our organization, if when they do my chart, they can't get to it because it doesn't have a Spanish option or it doesn't have a Vietnamese option. And it gets that granular with us. We need to make sure that we're capturing the ability, and especially in today's environment with telehealth, we have to bring the tools to the patients in the workforce for them to be efficient. And unless we're doing that, we're going to struggle. So I really want to hear Lisette and Judy's spin, but it really boils down to going back to an old adage, even with IT, garbage in, garbage out. We need to set the data governance models within the EHR to be able to make that data usable and the outcomes something that will move the work forward. And I'll stop there and let weigh in.
So do you mind, Judy, if I go next?
Oh, go ahead. Yep.
So I think for me, when you think about health equity and the health disparities that exist in our country, it's incredibly important for us to be able to identify our patient population by demographic and understand the cultural needs, and to be able to create preventative healthcare plans in the proper way to the understanding in each of our demographic areas. And so one of the key things that we're doing, and you'll see it across hospitals across the entire United States, is the accuracy of the data that's collected. And to understand that there are two forms of data that are incredibly important for us to be able to create preventative healthcare measures. And that's called real data and SOGI data. Real data is race, ethnicity, and language data. And SOGI data is sexual orientation and gender identity. Those forms of data are incredibly important to be accurate. And there needs to be a collaboration with our patient access teams, anyone who enters registration data, whether it's within your physician practice groups, the medical centers. Those teams need to be involved and trained properly on how to ask the questions and how to troubleshoot when our patients have questions. And it's incredibly important to put those stops in your EHRs to make sure that if those questions are skipped, that you have an alert that they need to be filled in and the questions need to be asked, and there needs to be an attestation to asking those questions. There needs to be a mechanism to analyze and to audit the work to make sure that there is accuracy within the data, because this data is incredibly important. And that's another piece that I want to make very clear. These teams within patient access don't understand that the work that they do in providing accurate data collection helps to save lives in our community. When we understand and have accurate data, we are better able to create preventative healthcare measures and understand where the chronic diseases are really lying within specific demographic areas, and to create educational programs to be able to provide access and really target our social determinants of health and understand how to really manage them more appropriately when we have accurate data. Instilling that pride in that work is another piece to the equation. And also helping our patients. We need to also educate our patients with materials so that when they walk into a registration area, they can see posters and understand that we ask these questions because we care about you and we need them in order for us to be able to create these measures to really bridge the gap within health disparities within our community. So that accuracy in the data is incredibly important. And if you analyze your patient population data right now and measure and look at what it looks like by hospital, you'll see that there might be some imperfections, and you might need to, and if you do see that, you might need to instill some education throughout your system.
Yeah, and some education, and also to build your EHR. And you mentioned it, Lisette, just something as simple as gender options. Is there an option for transgender? Is there an option for non-binary? Mm-hmm. That needs to be embedded in the options of when you're registering that patient. And so if it's inconsistent across Jefferson, CHOP, Mainline Health, there's a disparity there and a gap that we have to address. And so that's really important.
And that's key, working in collaboration with other hospitals as well. And also don't forget that your MyChart systems don't run on the same systems. So whatever's in has to be aligned with your MyChart so that when patients actually update their profiles, they have the same options. So
I think I agree with both of you. I think the accuracy is really important and the completeness is really important. And it breaks my heart when I look at some of the Department of Health data sets, or even some of our federal data sets, where 40% of race information is missing in COVID case reports. That gap so much impacts the ability of public health officials and others to address this epidemic. I mean, because our hospitals don't have those kind of gaps. Lisette, we are not 100% accurate in all of our data, but we don't necessarily have all of those gaps. We were able to use that information to really aid our municipal officials, industry leaders, business leaders, especially at the beginning of this pandemic, where in those workplaces where we saw a lot of infection and it was really affecting our Latino population, because we had the data, you could really move forward on how to respond. And so I think that's a place where I think healthcare organizations, if they do this well, can really be supportive of our local, state, and federal public health officials. So I agree with that. And then I think we also, though, need to be creative about how we collect, especially the SOGI data, the sexual orientation and gender identity, because those are really, really sensitive questions. And so we at LVH, we have a multifactorial approach to how we collect it. We allow patients to self-report that information. They can do it in the privacy of their homes before they come to, primary care visits, so that sort of my chart accessibility is really important, and functionality. And if that information isn't collected, we've trained practice staff on how to ask those questions in really sensitive ways. And even our practice staff kind of struggle a little bit because they don't want to offend patients. But then stories emerge, and I think you learn a lot through stories. And we have heard from patients who say, I'm lesbian. I never felt comfortable sharing that with my provider. But when you opened that door, when you allowed me to put that information into my profile, or you asked me the question in the practice, I finally felt like I was included, or that I really belonged here, that you cared about me. And those stories then really influence how staff can continue to collect this information. So absolutely critical. The functionality needs to be in our EMRs. And then we need the staffing, the staff education on how to collect the information. And then I totally agree. You need the follow-up, the auditing, to make sure that everyone is being accountable and we've got accurate data.
Yeah, thank you. So as in our last 5 minutes together, I would like, each of you to share advice to participants, just maybe a few final thoughts. And Lizette, I'd like to start with you.
Sure. A couple of things just very quickly on my advice in strategically creating a plan for DEI for your organizations is make sure that you really pay attention to setting accountability measures. It's a top level approach. You have to have your leadership focused to sustain this work. Also, number 2, begin planning education and awareness to build on the understanding on how to better connect with individuals, unconscious bias training, and anti-racism training, how to speak up, looking at discrimination, all of those things to build awareness. That helps build that culture of inclusion. And begin thinking about how you sustain that work throughout the institution. What we have been doing at Jefferson, we talked a lot about here, is that we have instilled diversity, equity, and inclusion councils by division in our colleges. And we have made sure that the top leaders have been assigned as executive sponsors with a structured approach and action plans that are measured for the impact on a quarterly basis. And having that plan to sustain the work will eliminate that ebb and flow that we all encounter in these efforts. We need to make sure that what we do is a part of the infrastructure of the organization to make sure that we really break down systemic racism within the institutions.
Judy?
I agree. I think the other thing that's really important to remember is that you don't need, you really want this into the pipes of your organization, and this is everyone's responsibility. So one of the joys that I have in my work is when I meet colleagues who are in a lot of different departments, and I know there's a few of them who are joining us today, who've really taken it upon themselves to advance diversity, equity, and inclusion where they work. And so how can we be supportive of champions across the organization so that everyone feels like they belong? And when we all belong, that's when we deliver the best care to our patients.
So I'll close it out with that, echoing both Judy and Lizette's comments. What I will say is get involved. There's a lot of work to be done. And what the pleasure of what I'm seeing here at Children's Hospital of Philadelphia is that there has been a lot of organically grown awareness within our areas of the institution, from standing up D&I committees within IT. We're standing up D&I committees within the Department of Medicine. And they have been really thoughtful in their approach, and it aligns with the overall strategy of the diversity, equity, inclusion plan. So that's one of the things I think is missing is that we are hesitant to do that because we want to control it all, but some great work is coming out of those spaces. And so I really would highly recommend that. And then self-awareness and self-teaching. The department is there as a support, but you have to do a lot of that learning on your own. So look for those tools, look for those opportunities to learn, look for those podcasts, look for those articles, look for those books to just self-educate on something you're feeling uneasy about, because there's plenty of literature out there. And we've created our website as a support mechanism to drive you towards those resources and tools. And then lastly, and I think Lisette mentioned this, help us make this sustainable. We need to have sustainability. We don't want to have a reactionary response to this. We want to be proactive. We want to stick to our strategy, but we want to make it sustainable as well. And in order to do that, we need input from everyone in the institution. So I would promote those things more than anything.
Yeah, Judy, Lizette, Gilbert, thank you so much for a great discussion this afternoon. I know that we do have questions, and we unfortunately are out of time, so we will do our best to get the answers out, after the fact. So thank you, everyone, and have a wonderful day.